today. Most of you will notice that you're muted. Please stay muted throughout the presentations just to ensure everybody can hear all of the speakers. My name is Alyssa Greiner. I am the Assistant Executive Director for Mondays at Racine Cancer Care, and we are doing this virtual symposium today focusing on men's health in partnership with Good Samaritan University Hospital and Catholic Health Cancer Institute. So thank you to them for partnering with us and for allowing us to be part of this great symposium today. We're really excited. There's a lot of great information that's going to be shared today and a lot of great experts who are going to be doing that sharing. So just quickly before we get started, I just wanted to give you a few quick highlights about what Mondays at Racine is for those that don't know. We are a nonprofit and we provide free services, health, wellness, beauty to anyone, male, female, young adults, any age bracket who are dealing with any kind of cancer. We are not exclusive to one type. And our only requirements in people being able to utilize our free services are that they're in treatment. So whatever that looks like, we understand there's certain special conditions sometimes. So treatment, and we can always, if you call and ask questions, we can help if, there's a special circumstance. But we are located in 18 locations across Long Island. We also go into medical centers, like partnering with Good Samaritan. And we hope that if anybody has any questions, you can always go to our website, mondaysatracine.org. These services are meant to help people going through treatment to feel better and look better. Treatment can be scary, it can be painful, it can be overwhelming, it can be many things. So for anybody who feels that they're in need, please reach out to Mondays at Racine. And in particular to today, speaking about men's health, men in general don't often ask for help. I don't think that's a secret. But, one of the things that we're hoping today is that with all the information that's being shared and provided by everybody, that men will start to ask for help and realize that there are a lot of resources out there that can really make a difference in, their health, mental, physical, and all aspects of it. And Mondays at Racine is definitely part of that. We feel it's very important to provide both mental and emotional support for men along with everybody else. So we hope that today, we'll be able to provide that information and hopefully have some more male interaction and, taking part in our programs and in everybody's services. So that is Mondays at Racine in a nutshell. I am going to kick this off we're going to start with prostate health, and I'm going to introduce Dr. Christopher Atala, who is the Director of Men's Health at Good Samaritan University Hospital. Dr. Atala, it's all yours.
Okay, thank you. I'm just going to share my screen here. Okay. So since it's Men's Health Month, we're going to be talking about prostate health today, and that incorporates all things related to the prostate, not just cancer of the prostate, but benign conditions as well. So first, we got to start with what is the prostate. We all know that men have prostates, but we don't always exactly know what it is, what it does, where it's located. So the prostate is a walnut-sized gland that sits below your bladder, and it sits around your urethra. And it's actually the organ that provides the seminal fluid that is vital for sperm and ejaculation. So with that in mind, there are different things that can happen to your prostate, and you may not realize that it's happening when it is happening. So there are certain disorders of the prostate that are very common to men, and it's a good idea to know what these things are, what they look like, in case you're experiencing some of these symptoms, you kind of have an idea of what may be going on. So things like BPH, which is enlargement of the prostate, prostatitis, which can be an infection or inflammation of the prostate, and then of course, prostate cancer. So benign prostatic hyperplasia, or BPH, this is an enlargement of the prostate that is benign, meaning it is not cancerous. Having an enlarged prostate does not predispose you to having prostate cancer. The prostate typically tends to start growing around age 40, around age 50. It's important to know that having an enlarged prostate doesn't mean that you'll necessarily have an issue with it. Some patients have enlarged prostates and never know they have it. They urinate without any issues. However, there are some men with enlarged prostates that have some symptoms related to that. And some of the symptoms of enlarged prostate are increased frequency of urination, waking up to urinate at night multiple times, straining or having to push to get the urine to come out, urgency of urination, weakened flow, and even urinary retention, which is the inability to pass the urine at all. So, typically, if you're experiencing those symptoms and your doctor diagnoses you with BPH, enlargement of the prostate, usually we'll start with medications to try and help improve some of those urinary symptoms. The mainstay of treatment is a medication called tamsulosin or Flomax. It's something called an alpha blocker, and essentially what it does is help relax the prostate so that urine is able to pass through the prostate more easily. If that's not working, sometimes your doctor will add a second medication called finasteride or dutasteride. And these medications can actually physically shrink the size of the prostate, usually by 15%, but sometimes as much as 30%. And those two medications are really the mainstays of treatment for enlarged prostate when men have symptoms related to it. The next line of therapy after medications, if they don't work, is to discuss surgery. The mainstay or the gold standard surgical procedure is something called a transurethral resection of the prostate. It's a minimally invasive procedure that essentially shaves down some of the prostate tissue so that the urinary channel is more open and allows passage of urine without resistance. Nowadays, there's more newer modalities that are less invasive than the resection of the prostate, things like using a laser to remove some of the prostate tissue, Urolift, which you may have seen commercials for on TV, which are small clips that hold the prostate open, and Racine, which uses steam to destroy some of the prostate tissue. The next thing we're going to talk about is prostatitis. Prostatitis can be broken down into multiple different categories, whether or not they are involving bacteria of the prostate, or if they're just inflammation of the prostate. So patients who have acute prostatitis, which means sudden onset, typically will have symptoms like painful urination, difficulty urinating, pelvic pain, and fevers and chills. Versus the flip side of that is something called chronic prostatitis, which is something that's been ongoing for a long period of time. They can have similar symptoms, but to a lesser extent. So things like painful urination, testicle pain, painful ejaculation, pain in the perineum, which is the space between the anus and the testicles, and pelvic pain. The treatment for each of these is different. Acute prostatitis typically requires a long course of antibiotics, that medication Flomax that we talked about earlier. And sometimes when it's bad, when patients have high fevers, they require inpatient stay at the hospital to get IV antibiotics. Versus chronic prostatitis, sometimes antibiotics works. Oftentimes the treatment is focusing on the specific symptoms that that patient may have. Not everybody presents the same way. And so taking care of those symptoms based on each patient is really the mainstay in that case. Prostate cancer. So prostate cancer is the most common cancer in men. It's very common to the point that 1 in 9 men will have prostate cancer. The majority of cases are diagnosed in men over age 65. It's rarely diagnosed under age 40, but that doesn't mean it never happens. In general, African-American men have a higher risk of prostate cancer than non-African-American men. And the good thing about prostate cancer is that 90% of the time when it's diagnosed, it's localized. It has not spread or metastasized anywhere else. So the risk factors related to prostate cancer are age. As we get older, it becomes more and more common for men to get prostate cancer. Again, being African American and having a direct family history of prostate cancer, meaning if your father or your brother had it, you're at a higher risk of having it as well. People often ask, how do I know if I have prostate cancer? And generally the answer is that prostate cancer really doesn't have any symptoms. Later stage prostate cancer may have symptoms like difficulty urinating, back or hip or pelvic pain, and urinary frequency. So because there is no way to know that you have prostate cancer, it's often recommended that we do testing for prostate cancer, and that involves doing an annual PSA, which is the blood test that we use to screen for prostate cancer, as well as a digital rectal exam that would be performed by your family physician or your urologist. And who should be tested? All per the American Urologic Association, all men between the ages of 55 and 70 should be screened for prostate cancer using these two things, the PSA and the rectal exam. If you have a family history, excuse me, or you're African American, you should be tested earlier, as early as age 40. So how do we diagnose prostate cancer? If your PSA and or your rectal exam are abnormal, your urologist may recommend that you have a prostate biopsy. And what that is an office procedure that uses an ultrasound to take 12 samples of prostate tissue. It's done in the office using local anesthesia and usually takes about 10 minutes to do. So how do we treat prostate cancer if you've been diagnosed? The good thing about prostate cancer is the majority of them are curable. It's a slow growing cancer, and because of that, as I said earlier, most patients present with cancer that hasn't spread elsewhere in the body. There's three modalities for treating prostate cancer. One is active surveillance, robotic radical prostatectomy, and radiation. Active surveillance literally means to watch the prostate cancer, and that's for a very select group of patients with prostate cancer who have a low volume and low grade, meaning low aggressive type cancer, and that's something that you would discuss with your urologist. Robotic prostatectomy and radiation are both done with the intention of cure. Robotic prostatectomy is a surgical procedure that we offer at Good Samaritan Hospital. And this is essentially the way that this surgery is done now. Before the robot was invented, it was done open, which meant staying in the hospital for about a week, and there would be a lot of pain involved and blood loss. But now with the invention of the robot, patients are typically home the next day, minimal pain, and they do quite well. We also have an excellent radiation oncology center at Good Samaritan Hospital, and the team there does a very good job. So the discussion as to whether or not you should have surgery or radiation is something that you discuss with your urologist in terms of what kind of side effects are acceptable to you and how it may affect your lifestyle. And so it's on a case-by-case basis. So oftentimes people will ask, how do you prevent prostate cancer? There's no true regimen that you can say prevents prostate cancer, but in general, you should be living a healthy life. That means eating a healthy diet, low in fats, increase your fruits and vegetables. You should exercise and maintain a healthy weight. And of course, doing your routine screenings. Those are the main thing. So as long as you see your doctor once a year and get checked, that's the most important thing that you can do. So with that, I will say that you must have a happy prostate to have a happy life, and I will pass it on to the next speaker.
Thank you, Dr. Atala.
Thank you.
And if you just have to stop sharing your screen.
Okay.
Although we love that last slide.
Yeah.
Everybody loves a happy prostate.
Right.
Just want to mention one thing. We had just texted in the chat that anybody who has questions, we're going to have time after everybody presents. So start jotting down questions as everybody speaks. If you want to message them in the chat, we'll also collect them from there. So just, make sure that you're getting all your thoughts down and ready to ask when we're done with everything. And moving on, Angela Folan is next, and Angela is the lung cancer screening nurse practitioner for Catholic Health. And Angela, it's all yours.
Thank you so much. So I'm going to share my screen with you all. Okay. Great. So we'll get started. So thank you for the wonderful introduction. Again, my name is Angela Folan. I'm the nurse practitioner for the lung cancer screening program here. So today I'll be discussing some lung cancer statistics and facts, early screening, who is eligible and the criteria for screening. I'll give a brief overview of the lung cancer screening program here at Catholic Health, where you can have the imaging done, what an LRAD score is, and types of imaging results. So lung cancer is the second most common cancer in men and women in the United States. Lung cancer accounts for about 1 in 5 of all cancer deaths in the US. Each year, more people die of lung cancer than colon, breast, and prostate cancers combined. Lung cancer rates are decreasing nationally as fewer people smoke cigarettes and as lung cancer treatments improve. People with lung cancer are living longer after their diagnosis because more cases are found early when treatment is best. So what is lung cancer? It's an uncontrolled growth of abnormal cells in the lungs, and these abnormal cells may interfere, it may form into tumors that may interfere with the normal functioning of the lungs. Unfortunately, most cases of lung cancer are diagnosed at its late stages, and only 20% of patients are diagnosed at its early stages. Just another reason why it's so important that we screen our patients. So what are the risk factors for lung cancer? Cigarette smoking is the #1 risk factor for lung cancer. Cigarette smoking is linked to 80 to 90% of lung cancer deaths. Using other tobacco related products also increases your risks for lung cancer. People who smoke cigarettes are 15 to 30 times more likely to get lung cancer than people who do not smoke. The more years a person smokes and the more cigarettes they smoke per day, the higher the risk. Some other risk factors for lung cancer include secondhand smoke, radon exposure, exposure to other substances such as asbestos and arsenic, and personal or family history of lung cancer. So what are the possible signs and symptoms of lung cancer? So most people with lung cancer don't have symptoms until their disease has progressed. However, some symptoms may include a new or changing cough, a cough that gets worse or doesn't go away, coughing up blood or rust-colored phlegm, unintentional significant weight loss, feeling tired all the time, new shortness of breath, chest pain, and a hoarse voice. Generally, we screen patients who are asymptomatic, meaning they don't have any symptoms. So if you do have signs and symptoms of lung cancer, you should consult with your healthcare provider. So early screening. The New England Journal of Medicine published a study comparing the outcomes of patients screened with chest x-rays versus low-dose CAT scans. Their results concluded that mortality rates were lower in the group of patients where low-dose CAT scans were used. The graph on the left shows that more lung cancers are identified using low-dose CAT scans compared to plain chest x-rays. The graph on the right shows that the amount of deaths from lung cancer were less when low-dose CAT scans were used as compared to chest x-rays, excuse me. So with better imaging, we're able to capture and identify lung cancers and have better outcomes. So lung cancer screening. With screening, we're able to detect disease prior to having symptoms. We use a low-dose CT scan to look for early-stage lung cancers. It is recommended annually, and patients who are eligible, it may be a long-term commitment, but we'll go into the criteria in a second. So screening is not a substitution for smoking cessation. We encourage all of our patients to quit smoking, as quitting cigarettes reduces the risks for developing lung cancer. So the criteria for screening, we follow the recommendations set by the United States Preventative Service Task Force. It's a grade B recommendation, and it recommends that we screen patients aged 50 to 80 years old, either current smokers with at least a 20-pack year smoking history, or former smokers with the same history who have quit smoking within the last 15 years. After they have met that 15-year mark, screening should be discontinued, or screening should be stopped if a patient has a health problem that may limit their life expectancy. So what do we do during our appointment? So it's a shared decision-making appointment. We discuss with the patient their benefits of screening, the potential harms and limitations, the potential need for follow-up diagnostic testing, the possibility of overdiagnosis, false positivity rate, and total radiation exposure. We discuss the patient's medical history as well as their social and smoking history. We also confirm and update this information in our electronic medical record. We discuss if the patient is having any symptoms. We counsel the patient. So we counsel on the importance of adhering to our annual screening program. We discuss the impact of comorbidities, their ability or willingness to undergo diagnosis and treatment. And if the patient wishes to continue, we then enter the order for the low-dose CAT scan. We also counsel the patient on the importance of maintaining cigarette smoking abstinence and smoking cessation. We do refer a lot of our patients to the New York Quits program, which is a great resource. So the risks and benefits of screening. The risks, we do, it is possible to have some false alarms with these images, overdiagnosis, the radiation exposure. And even though we do catch a lot of, abnormalities on these CAT scans, there's always a chance that things can be missed. The benefits of screening, you have a better quality of life with early detection. There's a greater chance of not dying from lung cancer since it would be identified. And we also can detect other diseases other than lung cancer with these images. So the benefits of using the program. We provide up-to-date information about screening and test results. We work with a multidisciplinary team of health professionals to address suspicious findings. We use evidence-based guidelines to avoid unnecessary procedures. We assist in reducing the stress of the lung screening process. We assist with smoking cessation. We will remind you of your regular screening appointments, and we will inform your primary care doctor and/or referring provider of the results. So patients always ask about the radiation exposure. So I included this graph really just as a comparison. So as you can see, low-dose CAT scans for screening is about 80% less radiation exposure than a diagnostic CAT scan. And we are constantly being exposed to radiation in our average environment. So where can you have these imaging done? We perform our low-dose CAT scans at any of our Catholic Health hospitals along Nassau and Suffolk County, as well as our freestanding facilities. So St. Francis Diagnostic and Hospital, Mercy, St. Joseph's, Good Sam, St. Catherine's, St. Charles, and St. Catherine's Diagnostic. How is the low-dose CT performed? So it's a very quick process. It takes about 5 to 10 minutes. It only involves laying flat on the CAT scan table. There's no need to fast or make changes with your medications. No IVs, no contrast is given. It's painless, it's non-invasive. Patients generally don't complain of any type of claustrophobia with the CAT scan since it is so quick. So once the CAT scan is done, it typically takes anywhere from 1 to 3 days for the results to come back to us. And once it is resulted, it is assigned a lung rad score. So a lung rad is a classification system that was developed by the American College of Radiology. It was first introduced in 2014, and it was designed as a quality assurance tool to standardize lung cancer screening, reporting, and management. It was used to reduce confusion in lung cancer screening interpretations and facilitate outcome monitoring. So patients can have these CAT scans done across, the country, and their LRAD score should be the same in all locations. So once the imaging is complete, each scan is reviewed by the radiologist. You will be contacted by a phone call from our office, as well as a letter will be mailed to you with the CAT scan results. We send the results to your primary and referring doctor, as well as the report is sent over. Annual program visits will be scheduled by our program coordinator until you do not meet the criteria for lung cancer screening. Normal results may mean the risk of lung cancer is low, but it's not zero. To reduce the risk of lung cancer death in the future, annual screening may be necessary. So what happens if the results are abnormal? This image on the right shows a lung nodule in the right lung. So an abnormal CAT scan doesn't necessarily mean cancer, but additional testing may be needed to determine a diagnosis. If an abnormality is detected, a follow-up with a specialist will be arranged by our team. We work very closely with interventional pulmonology. Evidence-based recommendations will be provided to your primary care doctor and or referring provider for follow-up. And sometimes we uncover incidental findings. There are findings that were uncovered during these imaging that was unrelated to the purpose of the test. Depending on the results, you may need to follow up with your primary care and or specialist if needed. For instance, sometimes with these CAT scans, we can see lymph nodes that are enlarged. We can see coronary artery calcifications. We can see a enlarged aorta. We can see stents that were placed previously, or there could be more benign, such as cysts or kidney stones, maybe some metal clips or a history of a healed fracture, things like that. So lung nodules can be a common finding that we see on these CAT scans. They're a small abnormal area in the lung. Most of the time they are benign, often as a result of old infectious, previous inflammation, scar tissue, or some other causes. Additional testing may be needed to make sure that the nodule is not cancerous. So we look at these nodules through the scan, depending on their size and appearance is when the follow-up would be recommended. So in the lungs, we measure things very small in millimeters. So if the nodule, let's say it's maybe 2-3 millimeters in size, it's safe to follow that nodule annually. If it's a little bit larger, we may ask for a sooner follow-up, maybe 3 months, 6 months, 9 months or so, just to make sure nothing changes during that interval. And if the nodule is, large and suspicious, we may also recommend a PET scan to help detect whether it is cancerous. Sometimes, this is generally done by our interventional pulmonology team, but sometimes tissue sampling or a biopsy is recommended as an option for diagnosis. I believe we're waiting for questions at the end, but
Awesome.
thank you.
Thank you, Angela, for the presentation. And yes, we're going to get questions at the end. So again, everybody, make sure you have those ready. And we also, another note, we posted in the chat a link to a survey that either when this is over or when you have a second, if you can click that and provide some feedback, we would greatly appreciate it about today's symposium. So moving on, our next speaker is Dr. Saeed Mahmood, and he is the Director of Cardio-Oncology at Catholic Health.
Thank you very much. Let me start by sharing my slides. Can you see the presentation view here?
Yes.
Okay, great. All right. So I am a cardiologist and I have done subspecialty training in the management of cancer patients. It's a privilege being here at Catholic Health and working with outstanding colleagues who are making a significant contribution for our cancer population here in Long Island. So let me start by just talking about cardio-oncology. So cardio-oncology is a relatively new subspecialty within cardiology, as I mentioned. And the way one becomes a cardio-oncologist is that in addition to the full cardiology training, which is about 3 to 4 years, we do a 2-year subspecialty fellowship in management of cancer patients, as well as so that we understand the toxicities they may be experiencing from their life-prolonging cancer therapy. And we also are trained to understand and manage the long-term effects of cancer as well as cancer therapy in cancer survivors. And this is a very hopeful time, in my opinion, because the population of cancer survivors in the United States continues to grow substantially. So in the 1970s, there were 4 million cancer survivors, and presently there are 18 million cancer survivors, and that number is set to increase to 24 million in the coming years. The cardio-oncology service at Catholic Health consists of myself, as well as my colleague, Dr. Howie Zhang, and my colleague, Kim Ward. In terms of our outpatient clinic, we are across the network. We have clinics at Good Samaritan Hospital. We have clinics at St. Francis and clinics at Mercy Hospital. And we have an inpatient service as well. So you could ask, well, who should see a cardio-oncologist? And the answer is any cancer patient. Because cancer patients are a unique cohort because historically, when it came to large cardiology studies, cancer patients were systematically excluded. Now it's one of the most common chronic illnesses that we see. And so that has sparked this new subspecialty over the last 2 to 3 decades. So we see cancer patients before they start cancer therapy in order to optimize them for chemotherapy, radiation, or surgery, keeping in mind the unique characteristics of our cancer patients. We also see patients during their cancer therapy because this is an incredible time for the field of oncology. We have revolutionized survival. As you may be knowing, about 70% of cancer patients are alive 5 years past diagnosis. This is an incredible achievement. The overwhelming majority are doing very well and are alive 5 years past their diagnosis. And some of these newer agents have is clearly a life-prolonging beneficial effect, but they can also have unintended toxicities in the heart. And nearly all these toxicities are manageable so that the patient can continue on the cancer therapy that gives them the best chance at a long, healthy life. And then I also run the survivorship effort here through the cardio-oncology program at Catholic Health, and we take care of cancer survivors because they're at a unique accelerated risk for heart disease. But all of these are easily managed, and that's what we do here in the cardio-oncology program, keeping in mind their cancer history and their chemotherapy history or radiation history. So why does the field exist? The field exists because heart disease and cancer share common risk factors. Now, many in the audience may be on a statin, and the way your primary care doctor or your cardiologist decided to put you on a statin was they actually plugged your information, your age, your gender, your cholesterol, your blood pressure, and your ethnicity into an equation that we use. And that equation gives a 10-year risk of heart attack or stroke. And based on that, your patients are placed on a statin. And we know that the higher you are on that equation, this is a 5-year risk of heart attack, a 10-year risk of less than 5% to have a heart attack or stroke. And this is like a 20% risk of heart attack or stroke in the next 10 years. We know that the higher you are, the more at risk you are for heart disease. So that's well established. But what we also found from this study was that the same risk score also predicts the occurrence of cancer. And so what I'm trying to demonstrate here is that cancer and heart disease share common risk factors, and they're often co-managed. If we were to look at the literature, and going back to the 1960s, there has been a substantial increase in the reporting of high blood pressure and heart disease among cancer patients. And this actually, I would say, is actually a sign of success because it demonstrates that survival has substantially improved for cancer patients. In fact, for many cancer diagnoses, they simply are chronic illnesses. And so this is an incredible time to witness the improvement in outcomes for our cancer patients. So in the field of cardio-oncology, we have our own international guidelines from the European Society of Cardiology, and we use these to provide, here at Catholic Health, to provide international evidence-based care for our cancer patients and our cancer survivors. So so you can think of cancer patients obviously as those who are actively going through cancer therapy, and then those who are cancer survivors. So when we think about active cancer patients, there are incredible agents that have been developed and are in development from our oncology colleagues that are revolutionizing the arc of survival for cancer patients. And sometimes these agents can have an effect on the heart, and our job is to manage them so that the patient continues on whatever cancer therapy is most beneficial to them. So what are some examples? So, androgen deprivation therapy, which is given to prostate cancer patients, or even 5-FU therapy and immunotherapy, which is also given to cancer patients, can be associated with a higher rate of heart attacks. There's something about the milieu of these agents. And again, the overwhelming majority of patients are going to be absolutely fine, but there are some who are at higher risk as a result. Agents that are given for prostate cancer and other malignancies can be associated with high blood pressure. And by the way, this is not always a bad thing. So for our renal cancer patients, if you're on a certain type of an agent that is called a tyrosine kinase inhibitor, and you have high blood pressure, it actually shows that that patient is going to have improved survival. It's a sign that the medicine is working, but at the same time, we have to control the high blood pressure and reduce their long-term risk of heart disease. There can be a weakening of the heart from some cancer therapies, as well as an inflammation or irregularities in heart rhythm or valve issues. So I list these not to say that to get you concerned, but rather to show that, yes, there can be some unintended effects on the heart, but these are well described and we know how to handle them. And our job is to continue your cancer therapy so that you can get the best chance of beating the cancer without impacting the heart. So let's talk about cancer survivors. Well, cancer survivors are a very unique population. These cancer survivors historically were not included in a lot of our trials, and neither were active cancer patients. And now we're understanding that, one, for many patients, cancer becomes a long-term chronic illness that can be managed. And with that, there can be higher rates of heart disease, hypertension, cholesterol, and diabetes. There's something about the milieu of cancer that does predispose to that. And I won't go into too much detail here, but if you were to look at breast cancer survivors at the 5-year mark and those above 65, there's higher heart disease. And in prostate cancer survivors who've received long-term androgen deprivation therapy, again, more heart disease. And the emphasis here that I want to emphasize is that this is all easily manageable. This is all easily manageable and we can help further improve and contribute to long-term survival in our cancer patients by helping manage heart disease and risks that were otherwise not appreciated in the general population. So what does engaging with the cardio-oncology service look like? Well, you'll be seen by one of our providers, and we take a detailed history in which we understand the cancer therapy you're going to get or the cancer therapy that the patient may have received as cancer survivors, and we do a physical exam. And then we come up with a cardiovascular optimization and surveillance program tailored for the cancer therapy, as well as the history of chemotherapy the patient may have received in the past. We do this keeping in mind that the traditional risk prediction models that in general cardiology we would use don't necessarily always apply to cancer patients. And therefore, we generally have to be thoughtful about what was the cancer therapy that they received and what are the long-term risk factors. So for instance, one of the most incredible agents that has come into market in the last 10 years is immunotherapy. In fact, the Nobel Prize in 2018 was given to the persons who helped develop this agent. It has revolutionized survival. And it's an incredible agent to be on that can be associated with accelerated heart disease in cancer survivors. And so we get involved at that point to help limit the risk from that. So what do? Well, we come up with preventive strategies in that we will start a patient on a statin, we will help control their blood pressure, we will monitor their diabetes risk, which may be accelerated in the setting of prior cancer therapy or from being a cancer survivor. And we aggressively treat pre-existing heart disease because we know that that's how we're investing in the patient's health a decade from now or 2 decades from now. It's a comprehensive approach in which we, one, educate the patient about what are their risks and what they can do to help mitigate that risk. And we see them, periodically to monitor them to pick up anything that is being developed and also take steps to help limit long-term effects of a cancer diagnosis and cancer therapy on the heart. We also heavily get our patients involved in exercise. We are extraordinarily privileged here at Catholic Health that we have an outstanding oncology rehab program. And this matters because, without getting into too much of the data, but there is outstanding evidence to show that cancer patients who exercise more have better cancer outcomes, including cancer patients who exercise during cancer therapy. Cancer patients are particularly at risk of being deconditioned because there's multiple hits that they may receive, and in the sense that they may already have obesity, hypertension, or advanced age, so they're not exercising. Then they're getting cancer therapy that can actually set patients back from an exercise physiology perspective. And whereas if we enroll them in exercise programs, there's increased fitness, better quality of life, and less cardiovascular risk factors. And so we often work we work very closely with our oncology rehab colleagues. We have physical therapists who are particularly interested in the cancer population and have expertise in the cancer population. And we know that this improves survival in our active cancer patients and also in our cancer survivors. Another thing that we do focus on is imaging to actually assess how the heart is doing during and after cancer therapy. So we do cardiac ultrasound. This is an example, and what you can nicely see here is we're able to see how the heart is squeezing and how the valves are doing, and this helps us understand the long-term trajectory of the patient. We also help get stress tests and cardiac CT to look at the blood supply of the heart, as well as cardiac MRIs. Cardiac MRI is this unique modality. We have an expert team here, and what it allows cardio-oncologists such as myself to do is look within the heart muscle to see if there's something that is happening after the patient has had cancer diagnosis and cancer therapy. And this is really a very sophisticated way of figuring out how the patient's heart is doing and how to set them up for long-term health and success. If you want to really think about the cardio-oncology program, you should think of us as cardiologists that straddle both the oncology sphere and the cardiology sphere, in that we will help these two services work together and improve survival for our cancer patients. In terms of cancer survivors, one of the most important things that we do is we advise about a healthy diet together with our nutrition colleagues, the importance of exercise, and then routine and periodic monitoring in terms of understanding the risk of heart disease due to the nuances of the cancer therapy or the cancer diagnosis the patient may have, and how to manage these risks long term. I'll conclude by saying, if you were to ask who should be seen by us, the answer is any cancer patient. We're happy to be of help. We are in multiple locations, and it's been a privilege working with my oncology colleagues here, because this is truly a remarkable time in the field of oncology, where many oncology diagnoses are now becoming chronic illnesses, and previously difficult diagnoses are becoming far more manageable. Thank you very much.
Excellent. Thank you, Dr. Mahmood. Lots of interesting information. And for anybody, again, questions, we will get to them after the next presenter. And to round things out today, we have Delaney Wahib, and she is a social worker an oncology social worker at the Catholic Health Cancer Institute, and she's going to be sharing a lot of great information about mental health and wellness. It's all yours.
Okay, I think I'm sharing my screen, yeah? Can everyone see my screen or no?
Yeah, Delaney, can you go start from the beginning? Click on
Yeah.
that on the left.
Yes. Okay,
Let's see, I don't have it yet.
okay,
Try it again.
okay, I just tried it again. Do you see it?
There
No?
you go. You got
You,
it.
you see it?
Yep.
Okay, and everyone can hear me?
Yep.
Okay, perfect. So yes, as Alyssa said, my name is Delaney Wahib. I am the social worker at the Catholic Health Cancer Institute at Good Samaritan University Hospital. And I want to thank everyone for taking their afternoon to spend it and listen to me talk a little bit about men's mental health and why that's important. So to piggyback off of how the MCs started this, the reason that talking about men's mental health is important is because men are unlikely to talk about their mental health. So they are affected by mental health, just as women are. However, they're less likely to have received mental health treatment because they are less likely to report any symptoms. Therefore, they're less likely to be identified as someone in need, and therefore they're in treatment less. But it is important that we get men talking and into treatment for a number of reasons, but mainly because chronic emotional problems can severely impact their ability to fully function, and it also puts them at a higher risk for suicide. So if you or someone you know displays some of the signs and symptoms that we're going to get into in the next couple of slides, it's important to discuss those and get into treatment as early as possible. The earlier the treatment begins, the more effective it can be, which is important. So the top 5 mental health disorders among men are depression, anxiety, substance use disorder, post-traumatic stress disorder, more commonly known as PTSD, and bipolar disorder. Today, I'm going to be focusing on depression and how that presents in males, and also oncology-related distress. Those are 2 areas that I spend a lot of time on here in my role at the Cancer Institute. So depression. Depression is a common but serious disorder that can cause symptoms that disrupt how an individual feels, thinks, and handles their daily activities. Depression presents differently in men and women. Briefly, women present in the more traditional way that someone may think of depression, as far as maybe being tearful or sad, crying, right? Kind of that more traditional view. Whereas men, what's important to note for depression is they often present as very irritable and angry, which also adds to the difficulty in practitioners working with them, right? It's difficult to work with irritable and angry people. So that is common and often missed by people. They don't think someone that's angry is depressed, but oftentimes with men, that's the #1 symptom. So if you take anything from this talk today about men and depression, that is it right there, that they will present as irritable and angry. So moving on, a couple of other signs and symptoms would be loss of interest or pleasure in hobbies, activities, decreased energy or fatigue, a change in appetite or unplanned weight changes, either way, losing weight or gaining weight, eating more, eating less. Difficulty with concentrating and decision making, which comes up a lot in my role here at the oncology center. And I think we talked about sleeping, but if not, and difficulty with either sleeping too much or too little. So risk factors for depression, while the exact cause is unknown, it's likely it's believed to be a combination of genetics, environmental, and psychological factors. In general, unfortunately, 1 of every 6 adults will have depression at some point in their life. And although everyone is different, the following factors may increase a person's chances of becoming depressed. Those include experiencing a traumatic or stressful event, family history of depression, that's huge, medical problems such as cancer, chronic pain, stroke. Obviously, I see a lot of cancer and chronic pain, and going through a major life change. even if those changes are planned for, they can cause a lot of stress, which can turn into depression. So it's important to remember that, a lot of us, especially in our adult lives, we're going to experience ups and downs and have some good days, bad days, right? But that doesn't make us depressed. The important thing to remember about depression is that those symptoms must be experienced for at least 2 weeks, most of the day, nearly every day. It's also important to remember that they have to interfere with your day-to-day functioning and cause significant distress for the person experiencing them. Women, again, because they enter treatment more, they're diagnosed at a higher rate than men. However, as of this presentation today, more than 6 million men in the United States alone have been diagnosed with depression. Like I spoke about, depression can look different in men and women. And the important thing to realize about men, again, is that they present more angry and irritable versus sad or tearful. So how is depression treated? The good news is that depression, even in the most severe cases, can be treated. Again, the earlier that treatment begins, the more effective it is. Treatment is usually treated with combination therapy, and that usually includes medication and psychotherapy, or CBT, which is short for cognitive behavioral therapy, which I will get into later in the presentation. And again, an important point that I want to bring home is that if you are experiencing any types of these symptoms, don't suffer for an extended period of time. Make an appointment, get in to see someone, again, because the earlier that you're treated, the better the outcome is. So talking a little bit more in depth about CBT, it is a form of psychological treatment that has been demonstrated over and over again to be effective for many problems, including depression, and it's very well in treating depression. Basically, what CBT's kind of core is that the belief is psychological problems are based on faulty or unhelpful ways of thinking, or a pattern of thinking. So people suffering from psychological problems with CBT can learn better ways of coping with them, and being able to better manage the symptoms and have a productive life, right? So it basically teaches someone how to stop the negative thoughts and have better ways of thinking. And once that happens, your behavior changes in a positive way. We use this a lot. You can use this in private therapy. You can use this chairside, bedside for brief interventions with patients. And basically, once the person is able to replace those negative thoughts, you'll see a behavioral pattern that will change. Excuse me one moment. So although there's always a role, right, for traditional treatment, I think sometimes people get a little freaked out, or they don't want to enter traditional treatment. So some helpful things that individuals that are experiencing these symptoms can try outside of traditional treatment. 2 ideas that I'll give you are to practice thought stopping technique. And that's similar to what we spoke about with the CBT, where you want to try to stop those negative thoughts in the moment. And that way you don't spiral out of control. And you want to replace those thoughts with something positive, right? So every time you have a negative thought, the idea is that you'll stop at that point in time, write down either in a notepad or your note section of your iPod or iPad. And then once you have those negative thoughts, you replace them with a positive thought, and you can refer back to your list throughout the day. A personal favorite of mine is called the attitude of gratitude. And really, it's exactly what it says. It's really just, you want to try to find a little bit of thankfulness or joy in each day, no matter how big or small. And it does, at baseline, sound a little, I'll say cheesy, but it really, when I tell people and I get feedback from my patients, this is a good one. So I practice this in my daily life, and it definitely helps. And the feedback I've gotten from patients is that it is helpful. So to piggyback off of depression and just talk a little bit about what I see here at the Cancer Center, I'm going to talk about distress during cancer care. So what is distress? Distress is an unfortunate and an unpleasant emotion, feeling, thought, condition, or behavior that affects the way you think, feel, and act. Unfortunately, although distress is normal during cancer care, every person that's diagnosed with cancer, no matter what, will have some distress at some point in time. So examples of distress include sadness, worries about finance, paying bills, employment, fear, worry, helplessness, feeling out of control, frequent thoughts of illness or death, concerns about taking others, whether that's if they have young children or aging parents, and questioning your faith, purpose, and the meaning of life. And this is in the context of being diagnosed with cancer. So distress risk factors, anyone can become distressed, and they will with a cancer diagnosis, but some are more likely than others. A risk factor is anything that increases the chance of an event. So for oncology related distress, risk factors include having uncontrolled symptoms, that's often pain, having a severe illness in addition to cancer, lacking social support, having younger or dependent children. If you are older in age at the time of your diagnosis, limited financial resources, lack of stable housing, and pre-existing mental health conditions will put you at a higher risk for distress. So triggers for distress. Distress is more likely to start or worsen when a new symptom prompts testing. That increases patients' anxiety. Being tested for cancer and learning the diagnosis, having treatment-related complications. Waiting to start treatment is what I see the most and the highest level of distress. Once patients actually get underway, we see a significant decrease in their distress. Starting another type of treatment, learning that their treatment may have been unsuccessful, or learning that their cancer has progressed or worsened. And transitions in care also can lead to distress. This is an interesting one because this can kind of be on either end of the spectrum, where they may be transitioning to end of life from active treatment, which causes distress, or they may actually be transitioning to survivorship, right, out of treatment, and that leads to a whole different type of distress and needs on the mental health spectrum. So that's interesting as well. So screening for distress is a major aspect of what I do here at the Cancer Institute, and assessing distress is a key part of the cancer care. We use a screening tool from the NCCN, which is the National Comprehensive Cancer Network, and it is, there's a little photo if you can see at the bottom, but what that is the distress thermometer and problem list. And basically you pick a number 0 to 10, 10 being the highest, 0 being the least, of where your distress has been for the last week. And then it lists a problem, gives you a list of problems that you can check off. If you score 4 and above, you'll automatically be referred to the social worker for additional screening and in-depth assessment. The problem list simply helps me have a better idea of kind of where you may be at, but it's not fully necessary. We can get into kind of why you're distressed at that more in-depth assessment. So depending on your needs at that point in time of the distress screening, you may stick with me, or you may be referred out for additional supports. So treatment for distress is proper and frequent screening, for distress, education on mental health issues and distress, referring out to providers for whether it be CBT therapy, psychiatric medications. A big help in lowering the distress is having patients learn about their cancer diagnosis, treatment regimens. The more information they have, the better educated they are. We notice a decrease in their distress. Obviously practicing an attitude of gratitude. And interesting, circling back to what cardio oncology was talking about, exercise and walking, as long as it's tolerated and approved by their physician, will help significantly decrease their level of distress. So some resources that I use here for all of you to use. I have my contact information here as well, my email, and that's my direct phone number. I love hearing from people in the community. I love helping. So if you have any questions or concerns, or if you think I could be helpful, please don't hesitate to reach out. So I think that's all I have. Yes, I hope that was helpful and educational. Thank you so much for your time.
Wonderful. Thanks, Delaney. Great job. Lots of great information today. So we are going to open it up to questions. You can either unmute and ask the doctor of your choice your question, or feel free to submit them in the chat. Either is acceptable.
Alyssa, I see some in the chat right now, if you want to go through those first.
Sure. Yep. So let's start with these. The first question is, I know it is recommended that oncology patients get a cardiology workup, but is the opposite true? So for Dr. Mahmood.
That's a really terrific question. So what I'll say is that there are already guidelines for cancer surveillance in asymptomatic patients, colonoscopy, mammography, and then a PSA testing at some point, et cetera. And so those are generally considered sufficient. And at this stage of time, we don't go looking for we don't do a malignancy workup in patients with the pre-existing cardiovascular disease because the data has not supported that. And I think part of that is because, there's no surveillance guidelines for doing cardiac stress tests in asymptomatic patients, but there are very robust pre-existing guidelines. For instance, all of us, once we hit 50, are supposed to get a colonoscopy, et cetera. And I think that's what drives there not being guidelines for a heart patient to be screened for cancer.
Great, thank you. And Dr. Mahmood, just a follow up to that, you mentioned immunotherapy, and patients that are on it typically are more likely to have some sort of heart issues potentially. For somebody who's on immunotherapy, should they proactively, if their oncologist is not bringing it up, is it something proactively that they should discuss with them?
That's a great question. So, the oncologist, I would imagine, would have brought it up. There's a lot, so immunotherapy can cause autoimmune inflammation of your own body, pretty much of any organ. And that would have already been explained. I want to emphasize that the occurrence of cardiac complications from immunotherapy is rare. It's about 1%, meaning 99 out of every 100 don't have anything. And these are incredible agents. The standard of care should be, and is, that anyone who's getting immunotherapy is supposed to get a baseline EKG and some cardiac enzymes drawn, because we use those for comparison if we think the patient is in trouble. So, we see these patients in cardio-oncology clinic and get a baseline EKG and troponin, and that is the standard of care. Yeah.
Okay, great, thank you. We have another question. Does a regular when you go to your GP, do they do a PSA test automatically at the recommended age? And how is it administered? So Dr. Atala.
Unfortunately, the PSA is not considered by everyone universally to be checked on every patient. And so while many family doctors are checking the PSA regularly, there are some that are not. And so it's important to ask your family practitioner when you're going in for your routine physical or screening to ask if your PSA is being done. And don't just assume that all the blood work is being done that you need. The way that that's done is a blood test. So it can just be done with all the other blood work that you're having done by your family doctor at that time.
Okay, thank you. And there had been a follow-up question. Is prostate cancer hereditary?
Yes, it can be hereditary. Patients who have prostate cancer are encouraged to have their family members screened for prostate cancer. For example, if a man has prostate cancer and he has sons, I always recommend that their sons get checked earlier than he would have been checked, starting at age 40. Because there is a higher chance of having prostate cancer within the family.
Okay, and I see, sorry if I say your name incorrectly, but Seamus has their hand raised.
Seamus.
Seamus, I'm sorry. Go ahead and ask your question.
Dr. Mahmood, I heard that they've been working with stem cells to help repair like congestive heart failure or heart problems. Are you familiar with any of that?
Yes, so let me start by saying that, let me first answer by saying there's 4 lines of existing medications for heart failure, okay? And so if we were to clone a heart failure patient and we gave one of them none of those medications and the other clone we gave all 4, then the one who got all 4 medications would on average live 8 to 10 years longer. So incredible advances have been made. The stem cell literature has unfortunately thus far not borne out, okay? By and large, the consensus in the cardiology community is that while there were early studies that showed potentially that they were beneficial, that has not borne out. In the meanwhile, we have come up with these incredible medications that continue to prolong life. And this is actually a very hopeful time, in my opinion, to have heart failure. Because these medicines really prolong life extraordinarily well.
Thank you.
Thank you, Dr. Mahmood. There's a question for Delaney. For a new patient or somebody newly diagnosed, when they're being diagnosed, does the oncologist bring up mental health support? How does somebody who's newly diagnosed and overwhelmed know about the resources for mental health support? How do they find out and get that support that they might need?
Sure. So yeah, I can speak to our docs here in the practice that they're in tune with mental health. So I'm confident that in consults, they would pick up on that. But to ensure that we don't miss patients and they don't fall through the cracks, that is where the distress screening comes into play. So if you're a new patient and you're having a consult here for the first time, you may be screened for distress by one of our navigators. If you're having your first chemotherapy treatment downstairs, you'll certainly be screened by our nurses down there. We have flyers around our facility as far as mental health and being aware with my contact information. So there's several different ways that a patient may be identified by our staff here for mental health needs. And of course, if the patient mentions that in consult, I would be given a referral by the physician as well.
Great, thank you. And Angela, a question for you. Talking about genetics, aside from smoking being a key risk factor for lung cancer, what about genetics or other factors that contribute to somebody developing lung cancer?
Sure. So genetics do play a factor. We see the greatest instances of lung cancer among smokers. However, if you work with chemicals, asbestos, radon exposure, arsenic, that also can trigger or be a risk factor for lung cancer. I know frequent infections, personal or like I said, family history of lung cancer. So there are many different risk factors, but smoking is definitely the greatest.
Okay, thank you. We have another question here. I guess this is sort of general, so anybody can sort of jump in and take this one, but are patients from other facilities welcome to come to you? These methods of care sound amazing, and I hope that other hospitals begin to see the importance also. But until then, can they come to you if they are a patient elsewhere?
So I can answer that from the cardio-oncology perspective. That's an excellent question. Patients from from an oncology perspective, cardio-oncology perspective, I think the question is that would be asking that if they're oncology patient elsewhere, can they see us for cardio-oncology needs? And the answer is absolutely. In fact, we are the strategic partners from Memorial Sloan Kettering, so they send us all their cardio-oncology patients from Long Island. And as does New York Cancer and Blood, that we are entering a strategic partnership as well. And so we see patients from within Catholic Health, which is a vast population of very complicated cancers, and we see patients from all over. So yes, we are happy to see any and all patients. And then if the patient has a general cardiologist, they get to they continue seeing their general cardiologist. We are subspecialists, so we work with their general cardiology colleagues. And so you follow with us and with them, and we comment and help maximize your heart health vis-a-vis the cancer diagnosis or the fact that the patient is a cancer survivor.
Great. Does anybody else want to add to that, or Dr. Mahmood kind of covered it all?
Yes, anybody can come see us.
Okay, great. And this is another question. I know from breast cancer, family members can get screened for the BRCA gene. Is there anything that men can get screened for to detect their possibility of getting prostate cancer?
Generally, we don't do any genetic testing on patients routinely unless they already have a diagnosis of prostate cancer. Typically, the only screening that we do is the PSA blood test. Genetic testing can be done for men diagnosed with prostate cancer to see if they too have the BRCA gene, as they have linked that to prostate cancer as well. In which case, then family members would be checked for prostate cancer, for the BRCA gene, sorry.
Okay. All right, great. Does anybody else have any questions that they'd like to ask these amazing group of experts? Okay. Well, thank you everybody for joining us today. We really appreciate you taking your time to be here today. There will be an on-demand version of this posted on Good Samaritan social media and Mondays at Racine social media. And if anybody has any questions following this, please reach out to us, and everybody involved today will be happy to help in any way we can. And again, thank you and have a great night. Thank you, Dr. Mahmood.
Thank you.
Thank you.
Thanks, everybody.
Thank you. Bye-bye.
Thanks,
Thank you.
everyone.
Bye, thank you.